Hi, good afternoon, everyone, and thanks for joining us again for a UHN open forum, a virtual open forum. As you can see, we are continuing to practice physical distancing, which we know is so important in this outbreak. So I want to express my thanks to you as I have each time we've begun this. It's incredibly important work that you're doing. I want to thank every single one of you. All of Team UHN is contributing in many, many, many ways. We also have launched a gratitude page, which many of you will know about, and I think it's going to come up on your screen. And it's an amazing page. If you haven't had a chance to visit it, please do. We invite everyone to express gratitude to your colleagues using Slido, and you can get there by entering hashtag #ThanksUHN. And you can see on the screen some lovely, lovely compliments. And it's fantastic that we're doing this. I think it gives everyone a great boost at a time when we're all struggling to keep up with things. The number one shout out was to our housekeeping colleagues, and I think we're all delighted to see that. We know what great work they're doing. Let me read a couple more. So a big thank you to Susie. Susie Hoda has been so incredibly calm, professional, responsive, kind, and compassionate throughout, whether in small discussions across UHN or on nationwide news. Thank you so much. Hashtag thanks UHN and all nurses and doctors at the front line. We also had a great shout out to Louise Pothier, Manager, Allied Health at Bickle. She took on setting up the screening booth. She also supported the setup of the voice amp systems across all booths at UHN. And Louise has been working many extra hours going above and beyond to ensure the safety of all of you, our screeners. So thank you for that. Also, a thank you to everyone working directly at the hospitals, from doctors, nurses, admins, cafeteria workers, custodians, and everyone in between for risking their lives every day. I wake up every morning and have you in my thoughts, and I'm truly grateful for all that you do. Heroes. Another one reads, thank you to everyone who submitted these acknowledgements. Oh, that's my reading, sorry. Thank you to everyone for submitting these acknowledgements, and we'll share more of those at future open forums. If you do have a few minutes, I hope you'll go on Slido and enter again, hashtag #ThanksUHN. You can submit your own note of gratitude and scroll through the wonderful acknowledgements to recognize your colleagues. Before handing it over to Jill, I have some really good news, I think. Many of you have asked me about parking, and I'm delighted to let you know that a number of our very generous donors, including a number of our board leaders, have made donations to allow us to ensure that parking for the next month can be without cost to our frontline workers, and I'm so pleased and thankful. So I know that's something that you've wanted. A number of our other institutions are looking at similar models, but I'm happy to share with you that we'll be moving to that model. Give us a day or so just to figure out exactly how we'll implement that. There are lots of us, and to do so in a way that's efficient, effective, and not too frustrating for those of you who are trying to achieve it. So thanks to the foundation, and thanks to each of you who have brought this up as important. Now over to our host.
Thank you. So we have some people in the room today who will take their place at the seat at the table, and we have other people who are calling in to help answer your questions. After each open forum, we send out a recap of the top questions as well as a feedback survey, and we actually take the video and key you to the place on the video where we answer that question, so that's important to look for. Thank you to everybody who's provided positive feedback about the open forums and also suggestions for improvements. We are trying a slightly different approach today because we have so many questions about the same things. And there are really 4 themes, so I'm going to go through those 4 themes now, and we'll answer. And the themes are established by the votes that we receive. So the key themes today, and the first one, we're going to ask Susie and John Granton to answer. John's on the phone, Susie is here. So the first one is reusing masks. Then we're going to talk about hazard pay, and I'm going to ask Kevin to address that. Parking we've already addressed. I think the thing about parking is it is going to take us a little while to work through how we're going to do it. And then the last grouping is childcare. So for reusing masks, I'd like to welcome Dr. John Granton, who's the division head of respirology, and he's on the line to speak about this, and then to Susie Hoda for her comments.
John, over to you.
Thanks very much, Jill and Kevin. Can you hear me all right?
Just fine.
Perfect. I'm practicing social distancing. I thought of coming down, but I thought it's best for everybody if we continue to stay away if we don't need to be at work. So I'm talking to you today from my house by phone. So I'm really here today to talk about personal protection equipment, but really I'm here as a frontline healthcare worker. And I work in the intensive care unit, and I'm in line with a lot of the nurses and RTs, housekeepers, and everybody who look after the sickest in the hospital. And I also want to acknowledge that I'm a husband, I've got a family, I've got a sister who's a nurse at Toronto Western Hospital, and a brother who's an anesthesiologist and intensivist at London Health Sciences Centre. And so I come here today really as a colleague and somebody who is really also anxious about what's ahead of us. And I hope to be able to at least alleviate some of that anxiety today. And just that I have a vested interest in safety, my own personal safety, those of my family, and those of my family who are frontline healthcare providers like yourselves. And so what I want to do is touch on a few items. First of all, as it relates to personal protection equipment, what we have, how we are going to help you provide access to it, and how we're going to protect our supply. And I do want to shout out to people, as we've done already in the organization, and shout out to IPAC, stores, our safety people, emergency preparedness, as well as the frontline people, which I think are the unsung heroes sometimes, are housekeepers, transport people, and personal care assistants who are also facing patients who are coming in sick. And so thank you very much. So first of all, people have asked what we have. And I think this is a difficult question sometimes because we have stuff through the organization as well as what's in stores. And we are trying to take an inventory of everything that we have and understand not only what we have, but what we're using. And to that end, we've developed a dashboard that has allowed us to get some real-time data to get a handle on what we actually have in the organization. And this is important because it allows us to react, prepare, and provide a shift in how we practice, but also in what's available to you on the front line, and to ensure that you remain safe. And we've also implemented processes so that you can have 24/7 coverage with access to that material as you need it. And in the high-intensity environments like the emergency department, ICUs, and the operating theater, we're going to be replenishing stock more frequently, and the other units at least once per day, to ensure that you have what you need, and if you don't have it, you can get access to it. And so our goal is to always have inventory on the shelves for you to use. Now, the way we protect our stock is we can increase our input. We recognize that globally there is a challenge with supply chains related to being able to ship things from abroad and increased consumption globally. And so as a result, there is a threat to our supply chain, and we're trying to address that. We're doing that through creative intake, and people are providing donations of materials, masks, and other personal protective equipment with some of the most ingenious ideas of 3D printing and other things to ensure that we continue to have the right equipment for you at the right time when you need it. The other way that we can protect our stock is decreasing use. Just like your bank account, you can either make more money or you can stop spending money. And right now we need to stop spending money. And to that end, we need to develop, honestly, an ethic of conservation, all the while ensuring that you're still protected. And we're going to start rolling out strategies to help you ensure that we continue to have enough stock by reducing the amount of equipment that we're using, strategies to safely use masks and other things throughout the day so they're not simply throwing it in the garbage. And to that end, I encourage you to work with your managers and educators to start learning these methods and developing an ethic of conservation as we move through this. Because we recognize, as Kevin has said in the past, that this is going to be a marathon. In fact, it's going to be an ultra-marathon, and we need to train and prepare for it and ensure that we have what we need when we need it for as long as we need it. I'll leave it there, Kevin.
Thank you, John. Susie, you're going to add some comments?
Sure. Thank you, John. That was really helpful. It was such a good overview of all the concerns that we have around PPE and how each one of us needs to play a role to try and be good stewards of our PPE resources. I just wanted to comment on the fact that with us having implemented this new universal masking policy last week, we're asking you to do things a little bit differently. And I fully recognize how that can be challenging for everybody. We're not used to wearing masks throughout the day. We're not used to having the same mask on through the day and going in and out of isolation rooms with that mask on. And I can understand how that might make people feel uneasy. I think that what would be really important is feeling comfortable with how to wear that mask safely. And really, to that end, we'll have to be very careful not to touch our faces and to be washing our hands and cleaning our hands very frequently, wearing face shields over the masks when going into isolation rooms to protect the mask, and being mindful of when your mask might need to be changed out because it's been contaminated. So just to recognize this is a different practice. You know, our team is here, my infection prevention and control team is here, and your managers and a whole group of us are here to help support you to feel comfortable wearing the masks the way that we're asking you to wear them. But it is extremely important that we try to use these methods to conserve our PPE and keep ourselves safe as best as possible.
So, Susie, I think one of the issues around masks is the point of care assessment that healthcare professionals do. Can you talk a bit about that?
Sure. So yesterday, the Ministry of Health issued what we call a directive. It's guidance around how we need to be very careful to do what they call a point of care risk assessment before any clinical encounter, so any patient encounter. And they really wanted to emphasize that because there is a lot of unknown. And so before you go into a patient's room, it's really important to think about what you might be doing with that patient, not just about the status of the patient, are they COVID positive or not, but what am I going to be doing when I go into the room? And we also want to make sure that in that assessment, we're supporting you to have access to the right kind of PPE to support that activity. So for example, if you're going into the room of a COVID positive patient or someone suspected to have COVID-19 infection, and you think you might be doing something that would produce aerosols, what we call aerosol generating medical procedures, we want you to take that pause and think about that in advance so that you can access that PPE that you need, the N95 respirator to give you the right level of respiratory protection, as well as don the rest of the PPE that you would require before going into the room and caring for that patient. And so, I think that's a really important point. It's something we expect every day that we be doing routinely. We call it actually part of routine practices in infection prevention and control. But this was another thing that needed to be highlighted in the setting of some of the unknowns that are around COVID-19.
So, Susie, I'm going to refer to some of the comments on the screen. Are we supposed to reuse our mask even post-isolation case? So I think you've addressed that in terms of how people use PPE. The last one, I'm still not clear on droplet PPE for COVID patients. Are you saying after I come out of a room caring for a known COVID patient, I put my mask in a plastic bag in my pocket, as shown in the UHN video, take it out of the bag and put it back on my face to reuse? Please tell me this is not what you're saying.
That is not exactly it. So that video that we filmed was really to try and address a few different points of what we wanted to highlight that might be a little different from what we do when we normally don and doff our personal protective equipment before going into an isolation room. At the very end of that video, the person who was acting this out was shown taking off the mask and putting it into a plastic bag. That was just to indicate at times when you might go on a break, for example, or go for lunch and need to take your mask off, this is a way that you can, or one of the ways that you can carefully and safely store your mask. It does not imply that every time you leave an isolation room, you'd be expected to do that. In fact, the whole idea here is we think it would be better and it would help us in our conservation efforts as well for you to not be taking your mask on and off very often, but keeping it on and using it for extended periods of time over your shift until it is soiled or wet enough that you have to actually replace it. So that's really what we intended to show in the video.
Okay, thanks
Jill,
very much.
can I just add one comment? So I think
course.
we know in more recent directive or more recent information released by the Government of Ontario that this does come down to every clinician and evaluating the need, as Susie's mentioned. And obviously, we always want you to do that in any situation, especially in an outbreak situation. But we also have to be a bit cautious, and I know you all know this. We're very anxious about supply, and we're very anxious about the peak of this epidemic, which the epidemiologists have quite a broad range of how quickly or not that might arrive. So I hear dates like 7 to 10 days from now, and then I hear other dates more like 30 to 45 days from now. And we know the whole world is looking to procure particularly N95 masks. So as John mentioned, and as Susie has reinforced, it truly is, conservation is truly essential if we're going to ensure that it will be there both for you as you need it and for safety in the current situation, but also for those who need it at the peak of this epidemic, whenever that comes. So we all realize how daunting this one is and how scary at times it is. And we'll continue working with you through Susie and the occupational health team. And obviously the province is continuing to look at this model as well. So please stay tuned, and if you have any anxieties, talk to us, talk to Susie, talk to IPAC, talk to Occupational Health and Safety.
So I'm going to turn now, I think, to hazard pay. And I'm going to ask Kevin to address this because this really is not within UHN's control. So Kevin, people are asking about this. They've done it a number of times. And could you maybe talk about this, why it's a provincial decision and what we've done about it?
Right, sure. So as you all know, we have a highly unionized workforce in much of healthcare. Actually, UHN is less so than many places, but we do also have collective agreements in place, and we have a large number of workers. I have raised this at a number of tables. I know my colleagues have raised this at a number of tables. Your bargaining unit leaders have raised this at a number of tables. And Emma and Diana and their teams have raised it at the Toronto Academic Health Science Network table of Chief Human Resource Officers. So what we can't do, I'm afraid, is go out without our peers and go out without our funder, the Ministry of Health and Long-Term Care, and ultimately the Government of Ontario. I want you to know that we are working hard to try to determine what this looks like, how it would be implemented, what resources available, to whom it would apply if approved, and it obviously also has legal ramifications going outside of the realm of an existing collective agreement. So there are a lot of moving parts in this one. I think everyone is agreed that those who are closest to the front line, we would love to see how we can better remunerate them during this very challenging period. I don't have more information than that at the present time. I don't believe that Emma or Diana have more information than that at the present time. And again, we have been very clearly instructed that individual hospitals should not be dealing with these issues alone, nor frankly do we have the economic capacity to. So leave it with us. It's heard loud and clear. We are talking with the Minister and the Premier's office on this one, and we will be back to you just as soon as we get some clarity on it. And the questions, like you, we're asking, who does it apply to, what kind of time frame, with what kind of rates, how would it be administered, all of the questions that go from it's a great idea to we have to implement it effectively and fairly and equitably. So stay tuned. I know this was not one that will go away without a lot better resolution.
So the next, we've actually addressed the parking update, but for those who maybe didn't tune in at the beginning, perhaps you'd like to tell them again.
It's always worth repeating good news more than once. So I'm delighted to share that our foundations, the Western Toronto General Hospital Foundation, the Princess Margaret Foundation, and the Toronto Rehab Foundation have all agreed to make significant contributions to our parking costs. so that our staff working during this pandemic won't have to pay for parking. So we're going month by month on this one, and the foundations, again, have been approached by generous donors and reached out to some. I also want to recognize our very own board. A number of our board members anonymously want to subsidize your parking and are doing so with their own resources. So again, give us a day or two to work out exactly how we'll implement this and exactly how we can do this safely and effectively at a time when we must practice social distancing. So as always, it'll be important that we implement it smoothly and fairly. So stay tuned, we'll be back to you, but for the month of April, no parking costs for staff working on sites.
Yeah, I think the other part of that is parking also has to figure out, people have already prepaid their parking,
Right.
so that's another thing that they will have to figure out, and that will take a few days.
Yes.
Childcare. So I think I'm going to ask Diana to come and talk about childcare. We know that this is a pressing issue for many people. We understand how difficult this can be. So Diana, maybe you can address that issue.
Sure, thanks, Jill. So I do want to recognize that this is a difficult time for everyone, and particularly for those individuals with young families who, in addition to everything else that is going on, also now have to worry about childcare with daycares and schools closed. As an organization, we are committed to being as flexible as we possibly can to help you find solutions to this. And the answers will be different for each individual. So for some, you've opted to work at home and to juggle that responsibility with childcare. For others of you, there are individuals who are now working at home within your household who've taken on this responsibility. I know that other individuals have been able to flex their schedule in order to do shifts at a time that allows them to also provide childcare. And for some of you, none of these solutions will work. And that is why the Government of Ontario has put in place the Child Care Benefit, which is a 4 weeks up to 4 months of pay, where you can receive up to $2,000 a month. So that is an option also. I know that none of these solutions are perfect, but know that we are talking with other teaching hospitals and addressing, this is one of the issues that comes up regularly, and we're ensuring that our policies and practices are in alignment with the rest of the sector. So if things change, we will be shifting also.
Okay, so those are the 4 big areas where we've grouped questions. So now I'm going to turn to the questions that are coming in. The first one, I think it's really a 2-part answer. I will try a part of it. The healthcare professionals in Europe and U.S. are emphasizing the use of telephone to facilitate end-of-life goodbyes with loved ones. Can you please bring back the bedside phones or make several cordless phones available on every unit? This will have a huge impact on the patient and their family. So the first part of that is that our foundations have actually grouped together again to fund some iPads at the bedside, and those would be usable that way. In terms of bringing back the bedside phones, I think at this time that is not even remotely possible.
No, unfortunately, our telephone system is pretty antiquated, frankly, across many of our sites. And as you know, it's essential workers only, even if that wasn't the case. So bringing telephone technicians on site at a time like this to work in clinical environments would make it very difficult. So we will be using, as Jill has said, either cell phones or iPads, and for those who have equivalent on the other end, trying to facilitate visual as well as audio communication. But we share the view of this excellent question or excellent recommendation. We obviously want to do the best we can, particularly for those who are facing life-threatening or end-of-life situations. So we take it really seriously. All of the managers are on this, and we will make the technologies available. Unfortunately, they won't be bedside telephones.
So the second question, although for confidentiality you cannot say how many staff at UHN have COVID, but we deserve to know how many healthcare workers have been infected despite droplet precautions. PPE in China. China has said you must use airborne precautions. I'm going to ask Susie to address this. We deserve to know how many healthcare workers are infected. Why are we not as protected as our front lines? So I think there are actually two parts to that question, Susie, but can you maybe speak to that?
Sure. I mean, I think we all understand that for confidentiality reasons, we're not advertising who and exactly what numbers even. I don't off the top of my head know exactly, can't tell you how many people have been infected who are healthcare workers. But I think what's important to recognize is we're healthcare workers, we're also people, and we're out there in the general community. And it's very hard for us to know exactly where people picked up infection. So part of that question refers to the use of, despite the use of droplet precautions as part of the reason for infection occurring, we don't have a good ability to actually attribute infections to exposures within healthcare and the community, given just how much community spread there is. I think as healthcare workers, we know that we are potentially at higher risk than the general community to being exposed to this because we have people coming into the hospital because they're sick. At this point in time, there is no evidence out there to say that using droplet precautions for routine care is harmful or not enough. We do know there are times where aerosols that are small can be generated when we're caring for people, and we absolutely agree that we need to make sure that people are protected wearing the right personal protective equipment during those times, those aerosol generating medical procedures. But at this point in time, the WHO, the Public Health Agency of Canada, as well as the provinces across the board, Ontario included, and ourselves here at UHN, have the right policies in place to try and protect our healthcare workers.
So, Susie, I'm going to ask you to stay, but Kevin has something he wants to add.
Well, let me just add a couple comments, and Susie can correct me if she thinks I get it wrong. So one anxiety I have about the question is suggesting that by knowing how many would, if we knew it and we don't, would in no way alleviate the anxiety you should have about personal distancing and personal protection. So you have to now consider with community spread, anyone you encounter in any part of life could have it. The other piece is if you're COVID positive, you are not to be at work. So clearly, the issue of knowing if you're deemed positive and we know about it, either through occupational health and safety or the patient reporting it from a screening site in the community, you need to be away until there are 2 positive swabs post your infection.
2 negative.
I'm sorry, two negative swabs post your infection. Positive as in good news. Sorry, 2 negative swabs post your infection. So again, we're other than those who might be infected and are pre-symptomatic, it would actually give you no confidence, or should give you no greater confidence, number one. Number two, we truly do not know this information, and we only know the information about those who've reported that they have a positive test, and then they are off work until those 2 negative swabs occur.
Thank you. Susie, a Harvard study suggested healthcare workers were at 20% increased risk of infection compared to the public. Risk decreased once the Chinese implemented full gear, full suit, goggle, face shields, N95 mask and gloves. There were no further reports of infected healthcare workers. Why are we not as protected on our front lines?
I think that there's some really important facts put together in one question in this particular, point that was made here. Yes, as I mentioned in my last response, healthcare workers might be put at increased risk because of the nature of what we do. We see people who are ill and seeking attention in hospitals because of that. And so I think that this speaks to the importance of early recognition of those who could have COVID-19 infection and making sure that you're preparing yourself, doing that point of care risk assessment, putting on the personal protective equipment according to the protocols we have in place, the policies we have in place, so that you don't end up in a situation where you're exposed. And so I think that is something that we recognize. It's something that we as healthcare workers have to deal with, and all we can do is our very best to protect ourselves against that scenario. The second part of that is actually referring to using full gear, which includes full suits, goggles, face shields, N95 respirators, and gloves. In China, actually, they're not using N95 respirators routinely, but I think that sometimes it's hard to tell from the pictures we see in the media what exactly is going on. Yes, you have to wear the right kind of personal protective equipment when you're caring for people who might have COVID-19 infection or are known to have it, which includes the use of a procedure mask for routine care, eye protection or face protection with a face shield, gloves and a gown. Different areas in the world have different types of personal protective equipment that they are more accustomed to wearing. Like these full body suits that we see are common in some parts of the world. We don't commonly use them here, and there's no reason for us to suspect that we need to shift into using that kind of protection over a gown. And in fact, when you switch what you're used to wearing in the setting of an emergency, it can lead to a lot more errors in terms of putting it on correctly and especially taking it off correctly. And that's something that makes me very concerned, because the highest risk of contaminating yourself and possibly leading to infection is in removal of personal protective equipment. We did do some very thorough usability testing back in 2015 for Ebola preparedness on what kind of personal protective equipment would be safest for use for managing patients with Ebola, which is a very different kind of infection, but we were very, very interested in knowing how we could have the best possible barrier protection for that disease. And what we learned from that is actually very helpful in this setting too. People were contaminating themselves much more frequently, removing these full body suits and these extensive pieces of personal protective equipment because they're bulky, they're hard to dispose of, we're not familiar with them, and so they're getting flustered, and it was actually a negative experience. And I think that that still translates to this scenario, and we want to make sure that people are comfortable with taking off their personal protective equipment.
And Susie, when you say that they were they were breaking protocol, you were doing the glow test, or how did you know that?
Yeah, so when we did those experiments, we actually had it all filmed, and it was reviewed by infection control, as well as we had human factors, healthcare human factors as part of this. And there were some glow germ experiments that were done, but that wasn't the main issue. It was actually very apparent just by watching and getting the feedback of the healthcare providers after the fact, what was going wrong, and where those areas of vulnerability were.
Okay, the next one is also for Susie, and it's about N95s with intubated patients, saying that we skipped this question the last time. Intubated patients have their circuits disconnected during the most mundane routine tasks. When this happens, it becomes aerosolizing. As a result, N95 should be a requirement during the care of intubated patients. Please address this.
So this is an area of controversy, and I think many people who provide respiratory care and those in infection prevention and control recognize that circuits can come apart, and you might have to deal with that while in the room of an intubated patient. However, that doesn't generally release a lot of aerosols. It releases a lot of droplets. So it is absolutely important that you have face shield and face protection on, but also the procedure mask for those kinds of circumstances. It generally doesn't result in small aerosols that would actually travel through the airborne route or require the N95 respirator. So I think that it's important to know that with our usual PPE, you would be protected if that were to occur and you were in the room.
And I also assume that you would know why that patient was in the room, and there would be many reasons for intubation.
That's right. I mean, we can't forget we have other intubated patients as well. And while a patient is intubated and being cared for routinely, they're in it's a closed circuit, and it's actually a safer environment. So not that you should let your guard down. You should always have your guard up and be thinking about what could happen, what you might need to do while you're in the room that could potentially generate aerosols. I mentioned this at the last open forum, but I'll mention it again, that we do sort of have a list of what is considered aerosol generating medical procedures that we all agree upon, and Public Health Ontario has released a similar list, and that's a good reference for people to go to if they're not sure about whether something is an aerosol generating medical procedure.
Okay, I think the next one, Kevin, is probably for you, because it is, we know that we have addressed this. If we become sick, will UHN pay for a hotel room so that we don't infect our loved ones at home?
So again, thanks to our foundations, we've been fortunate to secure a number of hotel rooms. Most of the donors have asked that they be for healthcare workers who are working, who don't want to go home, or who are too far away to go home. Let me go back and confirm with our foundations that our donors would be supportive of that. I suspect that they would. Obviously, one of the considerations in a situation like that is what kind of care would you get and need, and is a hotel room the best place for you? But we'll certainly, we do have hotel rooms booked. We do have generous donors who are making them available. So we'll certainly look at this one as an option, as well as those who wish to continue to work and don't desire going home because either of distance or anxiety about infecting someone who might be immune compromised or at high risk at home.
Diana, I think this one is about daycare and about the difficulty in working from home when you have young children. I don't know if there's anything that you want to add, or just hang on while Diana comes to the phone.
So, yes, I can well imagine the difficulties of working at home while also trying to care for the kids who are actually stuck in the house and probably a bit rambunctious too. I guess what I would suggest here is that there is the ability to not take a full leave of absence, but to work with your manager to see about reduced shifts, alternate times to come in a casual or part-time basis, where you might be able to do some of your work from the hospital if you're able to arrange childcare. Other than that, I really at this point don't have a different solution.
So the only other one that I've had a couple of colleagues mention is, and I know this is hard because it's virtually working one way or the other the whole day, but can any of your work be shifted to when your kids might be sleeping? Recognizing that when kids are home 24/7, sleeping isn't high on their list. So, we are open to exploring any and all options that work best for you. I think obviously there is not a simple, easy solution to implement en masse, unfortunately.
So I think the next question, Kevin, I'm going to ask it of you because it really deals with the commission that happened after SARS. I think Susie's spoken quite a lot about why we're choosing to do what we're doing, but maybe you could address this question.
Sure. So the question, as you can see, refers to erring on the side of caution or precaution when there's no scientific certainty. I agree with the questioner. There is no scientific certainty at the moment. We should be wearing N95 masks with confirmed or suspected COVID coughing or ventilated patients who can have circuit disconnect, which aerosolizes sputum. So Susie has talked about this, and I agree with her. I think one tries to go with the best evidence we can. I think we heard yesterday from the ministry, this does come down to an individual clinical judgment. And if you're making clinical judgment, the request that we have of you, and unfortunately because of the supply chain challenges we have to have of each other, is it a legitimate use of an N95 mask or other personal protective equipment? So just to reinforce, if you can, rationalize and defend why that's an appropriate use of a very scarce resource at a time when we know we're still very much on the incline, it is left to the individual clinical judgment of the practitioner. If we end up running out of these N95 respirators or getting close to running out of them, I think the entire province is now struggling with what are our options. And some of those options that people are considering, and again, we're looking to other jurisdictions, can they be reprocessed? So I know that there are other jurisdictions like New York that are saying they can be reprocessed 3 to 5 times. Unfortunately, none of these are optimal solutions. We would like an unlimited supply of these, and you would like great scientific certainty. We know that won't come for some time. So what we continue to ask of you is to use sound clinical judgment and consistency, and we will be as supportive as we can. But I can't leave the discussion without the focus on conservation, just not knowing how much more we'll be able to receive as the peak arrives. And as you know, literally every healthcare facility in the world is procuring these masks. There are simply not enough of them for everyone to get as many as they wish.
So I'm going to ask Diana to come back to the phone, the microphone, because this is about redeployment, and there is a suggestion here. Given the no visitor policy enforcement, many family members have been calling the nurses and requesting us to set up video calls with their loved ones. Unfortunately, we simply do not have the time or resources to implement this. Can we consider redeploying alternative staff or volunteers to take care of this? Diana.
I actually think that's a great suggestion, and would like to have the opportunity to talk to our clinical leaders offline to see what's possible and what type of worker would be ideal to do that work. So I'll take that back.
Okay, great. Susan Abbey's on the phone, so the next one is for you, Susan. If I'll read it and you can unmute. What is UHN doing to support the mental health of its staff beyond recommending EAP and a self-meditation tutorial? Many staff will require help beyond what can be offered via the EAP program and our benefits if we have them poorly address mental health or provide adequate funds for mental health support, I guess. Susan.
So I think that that's a really super important question. And we're doing a lot, and we're trying to pull together quite quickly and nimbly as many resources as we can from across UHN. Of course, with the recognition that many of these people are actively supporting patients in clinical volumes. So people are trying to take down their caseloads and be able to shift resources over to meet the needs of UHN staff members. We know that this is an ultra marathon, and that there are going to be different needs for people now, just as we're starting to have COVID patients at the peak or the surge, and then in the aftermath of it. And we also know that there's sort of really broadly, we can divide ourselves into two groups. Folks who have had some mental health challenges in the past and have been doing very well, but maybe have some sort of added challenges right now, and that we're going to need to help to provide support for. We don't see ourselves as replacement for community practitioners if you have those, but we also know that many people can't get a hold of their community practitioners and are going to need some help in that way. And then I think folks like a doc that I was speaking with last night who said, I've never had any troubles, and the anxiety I have now is just sort of blowing me away. I sort of feel sorry for all the people that I used to brush off about anxiety. So we know that this is challenging. Everybody in the senior leadership of the hospital recognizes this and is asking for us to get help to now and to have something that's sustainable for the future. We've pulled together senior leadership across both the Center for Mental Health and the Collaborative Academic Practice. So Mark Doucette from Spiritual Care, Mary Pat McAndrews from Psychology, Rebecca Fulton from Social Work, Heather Gordon, Wellness, and Natasha Bloomberg from our Emergency Preparedness. So everybody is working together. A real group of psychologists have come together to help us. Leslie Rattan is going to provide some leadership around that, and Robin Green. So we've got lots of folks working, lots of things happening, and I think you'll start to see some tangible resources out there by early next week.
Thanks
We're going to take what we call a stepped care approach, which means that we're going to have resources that people can access on their own and use. We're going to have some online groups that people can just, join in. No kind of low barrier, no commitment involved. And we're also trying to develop one-on-one, both single session and brief psychotherapy, as well as consultations with psychiatrists. So we're trying to get these up as quickly as we can so that you can access it when you need it, and that we have these resources available throughout the course of the pandemic.
Thanks very much, Susan.
Jill, I'll just add one other comment or two, perhaps. One, the Ontario Hospital Association is very actively engaged, as is the ministry, both the Ministry of Health and Ministry of Labour, in looking at how to fast-track resources for resilience in mental health and well-being. So they'll also be dovetailing into the work that Dr. Abbey's mentioned, and it is a regular discussion at the command table.
The next one, Kevin, I think is for you. Will this platform be removed now that someone snitched? This has been a greatly appreciated opportunity for staff to voice concerns without fear of being exposed to managers. Despite challenges, senior management have provided transparency and support, and we do thank you for that.
So I'm not aware that anybody snitched, and nobody should be worried about that. But if there's a good snitching rumor, I'd love to hear it.
I think it's the Toronto Star.
The Toronto Star. Got it. Okay. Well, the headline was less than desirable, but the article was pretty factual. So I'm always good with the truth, and I'm no problem with that at all. This exists for those of you who have the time or are scheduled at a time when you can join us for our regular open forums. We use this tool regularly, and this is a great suggestion. Maybe with Ingrid and Jill, we'll think about a portion of those open forums being some generalized roll-up questions. Even now, there is the opportunity to pre-vote so that they self-populate. But if there are areas you want us to address, sure, we can continue to build this in.
Yeah, I would just add that when the questions came to me from the Star, from the reporter, what I read in the questions was fear.
Yeah, of course.
And I think that we all have to understand that and be supportive of people. But I think openness and transparency, there are many organizations who are following this model and saying we really actually need to be open with staff.
So not everyone will have read the Star article. I'll just make a quick comment. The Toronto Star article, and I'm going to forget the exact headline, but it talked about disenfranchisement of staff at UHN. And, you know, for those of us who deal with the media more often, we learn early on that the person who writes the headline and the person who writes the story are usually two different people. So the headline, when I saw it first, was a bit jarring, and I thought, wow, that wasn't my reflection on these great interactions. But when I read the article, it was very clear, and it really the article pulled out what you were anxious about and what you were worried about and what we're all worried about, and some of the anxieties about what's happening or not happening as quickly as we'd all like. So for those of you who didn't read the article, it's still online. I'm sure you could have a look at it if it's not behind the paywall now.
No, it's
still open.
Yeah.
And I think the other piece, I just would want to make one other comment about the question. And I hope, like, our managers are some of our most valuable resources here. So the theme that you should be afraid or exposed to your manager really does concern me. And I know we won't focus on this while we're dealing with COVID, but managers are our colleagues, and they have really tough jobs in the meat and the sandwich between working most closely with our frontline staff and also with those they report to who are looking at mundane but necessary things like budgets and volumes and issues that are relevant to the Ontario Labour Code and human rights. So I just in the question want to also recognize that we have an amazing group of managers at UHN. If your fear of being exposed is there, we want to do some work on that when this is over. And I know Emma and Diana and the team are very focused on that normally. But, you know, obviously that's a bit concerning, and we want to not lose that thought.
Yeah, I would add that I think anonymity lets people really demonstrate what their true fears and concerns are. The only thing that we ask is that anonymity is not used to attack people or to be disrespectful to people. So somebody is just telling us they appreciate the open forums, and we will keep doing them. We certainly are not going to stop. Should we not be allocating more masks and PPE to the ED and ICU? My understanding, and I'm looking at Susie if you want to comment, but my understanding is that those are two areas where PPE is made available.
Yes, I mean, so the idea of getting a couple of masks to get you through your shift as part of the masking policy that we implemented is not by any means to be interpreted as we're not going to give you masks when you need to actually exchange them. If you're working in an area like the ICU where they can become more contaminated more quickly, they can get splashes, soiled, wet more easily, absolutely you should be changing them out, and we would make sure that you have access to those masks.
I think the next question too, Susie, if you can help us with this. Can we as an organization start advocating to the government for mass testing? Physical distancing works, but we need to be a step ahead. If we identify, especially those who are asymptomatic, complete self-isolation will be quick to implement and can avoid the rare outdoor trips for grocery and whatnot.
I think in an ideal world, we would be able to test everybody, and we'd have the ability, the capacity in the labs to do that. We would have the public health system to actually follow up on all of those individuals and all of their contacts. That would be ideal, I think. However, we have to work within what our means provide us with, and at this point in time, we're just not able to do that. What we can do, though, is provide the advice that if you develop symptoms, you must stay at home and self-isolate, and really hope that people take the responsibility for doing the right thing. So from a public health perspective, I think that is what we'd have to do. We're absolutely trying to see how we can expand our testing capacity as best as possible, how we can do things better. That is something that we work with the regions and the province and federally on a regular basis. But the realistic or the reality for us is that we just don't have unlimited resources and capacity to do that kind of testing.
The next question, North York General Hospital and Michael Garron Hospital have asked for PPE donations and even handmade masks. Some staff at UHN are starting to make PPE from surgical drapes. Are garbage bags next for us to use as PPE? So the first thing I want to say is Ajay Pillai, Pillai, is working constantly with people who are volunteering to donate materials or to set us up with connections where materials, PPE might be available. I think, Susie, if you want to talk a bit about whether making masks is a good idea. Somebody told me this morning that the things that you use in vacuum cleaner bags, probably that material is quite effective at stopping things from moving through. So
yeah, I mean, it is a bit of a challenge because we're in healthcare and we have certain standards that we would need to meet in terms of materials and the way that something's actually designed and constructed so that it actually will be protective. And the last thing we want to do is, give somebody something that's ineffective and lead them to believe that they are wearing something that can be helpful. So the self-made masks are challenging. I think Health Canada put out a little bit of guidance on this that people can read, but just by searching on their website. But certainly for other personal protective equipment, there has to be a good, clear process to vet it and make sure that it's going to be effective and not have poor integrity, for example, and that it will actually be effective to filter out or provide the kind of protection we need.
So, Jill, can I just add a comment? Obviously, as long as we are able to secure the supply chain and get the appropriate supplies that we need and that evidence supports in their use, we'll continue to do so. I hope we're never beyond that point. If it gets beyond that point, that's exactly why there are tools being developed like the triage tool that we're hearing about for critical care. It'll be a dialogue with you. I'm sure the comment is facetious about garbage bags. Obviously, that's never going to be the case, nor will we ever ask people to put themselves in a situation where they're not safe based on the evidence that we know so far. So stay tuned with this. We'll be working very closely with you individually and collectively on this one. The great anxiety is supply chain.
So I'm just going to, I'll go back up to the question, but somebody is saying, who do we contact regarding donations for PPE? So I would say again, AJ, that's AJAY, Pillai, Pillai, is taking all comments about donations for medical supplies. Justin Young is the person who's been assigned to deal with all of the donations around food or hotel rooms or really anything else. There are many, many people in this community who want to support healthcare workers and are making the effort to be very generous. It's just that we've centralized that, and maybe you want to talk about it, Kevin.
Just to recognize, we have already received many, many, many items, masks, gloves, gowns. One of the important things for us is before we'd consider putting them into our regular stock is that we test them. One, that they're safe, they're effective, they're what they claim to be, and that we once we determine those things are true, they can enter our stock. But we've received thousands of items so far, and I know we'll continue to.
So, Kevin, this one, I think. We are short-staffed and overworked at TWHER. Several of our PCAs and nurses are home isolating and not replaced on a regular basis. We're constantly short-staffed, especially on nights. When will redeployment or changes to the schedule occur to help units struggling and prevent burnout?
So I had not heard this specifically about the ER at the Toronto Western. Let Emma and myself and Diana go back and work with Jan Newton, the vice president for the site, and Dr. Sam Saba, the ER head of service, medical director. Obviously, we have a redeployment opportunity, and we also want to align those with skill and ability. So I'm sorry to hear that that's been the perception. Let us go back and look at how we can make sure that that's not the case going forward.
So Kevin, again, because of the critical care provincial table, at the last open forum, leadership mentioned that there are epidemiological mathematical calculations done about when the surge may occur. Do we have an estimate of when patient volumes will start to surge? When are we anticipating the peak? Some countries reported peaking at months post-onset.
So again, it's one of those areas where I wish I could give you great clarity. I wish the science and epidemiologic modeling could give all of us great clarity. We have some of the most accomplished epidemiologists and data leaders in the world here at UHN and U of T. What I'm seeing and the data that's been shared both provincially and federally looks at a fairly broad range, and it's so much influenced by how much we bend the curve, how much we take the top of that curve off. So the earliest number that I've seen is 7 to 10 days from now. And laterally, I've heard numbers as late as the latter part of May, the last week or 2 weeks of May. Obviously, we will be evaluating that daily. Every 3 days has been when we've tried to aggregate the data, and the epidemiologists have been recalculating the data. So again, I wish I could give you greater clarity, but it's somewhere between 7 to 30 days from now, I would say, based on the modeling we've seen. Susie, would you agree with that?
Yeah, no, I agree. It really depends on what's put into the modeling assumptions. And as you mentioned, there are many unknowns that might influence that curve. And so we're hopeful that some of those unknowns will take effect and dampen the curve. But yes, it's a very variable range.
We've been doing social isolation for now physical distancing for a reasonably limited period of time. We also know that we are not at 100% compliance. So the greater we follow the directions around social isolation and hand washing and staying at home and following all of the rules that we've heard from public health and others, the greater probability that we cut the top of that curve off. And what that does, obviously, is stretch this out and over a period of time that allows the healthcare system to respond, as opposed to this huge peak where we don't have adequate resources, including things like beds and ventilators. So please continue to practice physical distancing, hand washing, and all the public health measures that we've talked about.
So Kevin, I'm going to go to the one that's addressed to you. Dr. Smith, last open forum you said 98 to 99% of people will be just fine. What data informed this comment? The global death rate is 4.6%. In Italy, it's 10%. Over 40 healthcare workers in Italy have died. 15% of infections in Spain are healthcare workers. 2.6% in Canada will need the ICU. 50% of healthcare workers in China have depression.
So there's a lot of data in there. When we looked at the North American data and the curve trajectory that we were on, or believed we were on at the time, it looked like the range was between 1% and 3% of deaths at the time. So far, we've seen, particularly in Canada, we're sticking around that 1%, guardedly with small numbers of cases so far. I think internationally, we also know that there was probably a larger denominator, so more people infected than we knew about. So again, the number drops from a percentage perspective. So I believe we're still working at that 1 to 3% mortality. Susie's nodding her head, so I think we're agreed on that one. I think on the other issues that you bring up, the global death rate and the World Health Organization address this, particularly in nations that don't have as advanced healthcare systems or as great a capacity in healthcare as Canada, that those things are particularly challenging. We know even in the Lombardy region of Italy, one of the challenges, of course, was an age distribution that looked different than Ontario or Canada, and may have accounted for a difference. But it also accounted dramatically for a lack of physical distancing and social isolation, that we actually saw people, even after the outbreak, continuing to congregate. Many of you, like I, will have seen the irate videos of Italian mayors going out in their communities and so angry that people continued to believe that it was just fine to congregate and that life indeed should just go on as it should. So that, in my opinion, that's contributed to that. Over 40 healthcare workers in Italy have died. Very, very sadly, in those cases, we've heard reports. Those healthcare workers have been asked to perform interventions, often aerosolizing medical procedures, with little or no protective equipment. And we saw a number recently. I know we reviewed one where a middle-aged physician was performing procedures with no personal protective equipment. Thank God we're not in that position, and we never will allow ourselves to become in that position, in my opinion. For sure, you've identified, as has Dr. Hoda, that healthcare workers are at an increase. The number estimated so far has been about a 20% increase in risk. In Canada, some will need the ICUs, and we are ramping up. We've gone from about 1,700 critical care beds to about 2,700 to 3,000 capacity. So again, we'll continue to push on growing that. And no doubt your latter comment, healthcare workers in China have depression. For sure, Dr. Abbey commented earlier, I think we all know there is significant risk for not only in the moment mental health challenges, but a post-traumatic stress disorders after these events pass us. And so we'll be very mindful of that, and we're already beginning to think about what PTSD services should be prepared for Ontario.
So we've reached the top of the hour. Is there anything that you want to close on?
You know what, I think each time we've closed really where we've started, and that is with sincere thanks to all of you. Thanks for the frankness of your questions. Thanks for all that you're doing. Again, this is a fast-moving environment. Some of the data changes quickly, as does some of the information. I hope you'll continue to tune in and share with us those concerns that you have. And again, thank you so much for all that you're doing. Please remain very vigilant on physical distancing, hand washing, appropriate use of PPE, and if you have symptoms, both get tested and go home.